policies and procedures we receive, it's impossible for that one person to be able to update and implement these policies into the rooms. And another problem we have is that updates are provided from different sources. So some from the ACI, some from the Ministry of Health, some from the local health district, and they're not all cohesive. So it's working out which ones to implement.
And also, updated protocols sometimes require a rollout of staff assessments for credentialing. So, for example, we have an updated protocol for central venous access, which requires an educator to assess our nursing staff or all staff, which is currently obviously absent. And this impacts on the workflow of the rooms when staff aren't credentialed.
So just to summarise, there's a lot of policies and procedures that we have to implement into our practice, and none of these policies can be interpreted on their own. They're all required to be adapted to our practice and put into place. It's important to update all the relevant staff to new policies and procedures as they happen, which reiterates why educator roles are so vital to ensure patient safety and best practice. And I mean, this is also good for staff morale, because it means that staff are in control of their workplace and they know that what they're doing is the most up-to-date and relevant practice. And there's a suggestion of orientation packages to help update all new staff to the policies and procedures. So this is just a list of a few policies and procedures that could be further implemented into our practice, and I think that we're going to talk a bit about that. Thanks.
So these are a few of the policies and protocols that we've referenced, and you can see that's plenty, and we have plenty more of those.
Just go back up.
That's it.
Yep.
Thank you, Sally and Claudia. That was great. Do we have any questions for the girls? Kathy? Yeah.
So I suppose what we wanted to allude to here is just to bring across to everybody that there are so many policies and procedures that we're trying to absorb into our practice. And for nursing alone, the hospital sends out updated policies for us to adapt within radiology, because not all of them are relevant. A lot of the policies are actually relevant for practices in the wards, not so much for radiology, where we've got scrub and scout roll. We don't have enough staff to cover all of those in all 3 interventional rooms. So it's very hard to have those discussions sometimes. It's also hard difficult when we get a directive from nursing executive that a policy has to be rolled out into our practice, and trying to convey that not only to our own nursing staff but our colleagues as well, because it's something that's going to impact on us. We have to be credentialed. So one thing that we with the new CVAD, central venous access devices that came out, there was a new policy that came out last year about how they were to be managed. So one day we were able to manage them in our current practice, and we actually immediately had to stop and try to explain to someone why yesterday we were able to access them doing a simple technique, and today we can't. And it's not that easy to find someone to come down to the department to help credential us. So one of the things we've had to do with safe management of blood products, etc., we've had to set up some scenarios so we don't get the number of patients down with blood transfusions that we can actually credential 20-odd nursing staff. So we've established that we can actually do some fake patients or fake arms, fake blood products running through, and credential ourselves that way. And so that brings with it a whole lot of other issues about how do you maintain those sorts of skills. So it's trying to get that balance on training staff appropriately, getting it done quickly so that it doesn't minimises the impact on workflow, and making sure we stay abreast of all the changes. So no one accepts the fact that if we make a mistake and there's been a policy set out which would have addressed that, we didn't know about it. And we've tried to open the department up so that we actually are becoming aware of these policies sooner rather than later, or in a timely way. But that's one of the challenges when you're not working in a ward, working in areas like this. That's it.
I think, well done, girls. That's RPA's proactivity in trying to do this in a lot quicker fashion is great. When I sent the program out, I also sent out a list of the policies that you can access, and there's some out the front of the room. It is important to remember things like just staying agile and keeping track of this, because even if you have a folder with all your policies in it, you need to go and check on the New South Wales Health website often, because policies will be updated and you won't know about it, and you're looking at an old one still. So that, for example, the correct patient, correct procedure, correct site policy no longer exists. It's been replaced by the clinical procedure safety policy. But what most people don't understand is that was written by the CEC, so it's all changed now from the ministry to the CEC. They're still writing that. So what I'm saying is just you might put a whole bunch of local protocols in place, and in a very short period of time from now, they're going to reintroduce the clinical procedure safety policy with a far more robust description of how to use either the theatre checklist or the medical imaging checklist. So, you know, those are the sort of things you need to look out for, and just stay flexible, because I know what happens is when I've sent new things out, people just say, oh, we've just written the protocol, so we're not going to change it now. But you have to stay safe, so it's important to keep track of what's going on. Thank you.
I'd like to invite Ron Shnier up to the podium to tell us about, Ron's a radiologist, of course, that we know well, and from the Neuroscience Research Australia, and has long experience in MR. And tonight he's going to share with us his knowledge about prostate MR and PIRADS system. Thank you, Ron.
Thanks, Warwick. So we're going to talk about the new PIRADS score, and before I talk specifically about the score, I will just put some context of why MR is important. So if you look at current clinical practice, or should I say recent past current clinical practice, and still to this day, one of the paradigms that urologists use to choose about whether or not to go for biopsy is digital rectal examination only has a sensitivity of about 33%, 37%. PSA, while it's highly sensitive, is not specific, around about 36%. 20% of men who have a PSA of less than 4 have prostate cancer, and 70% of men who have an elevated PSA don't have prostate cancer and never develop clinical disease. And biopsy, trust biopsy, which is still the gold standard, has about a 25% false negative rate. So if you think an average prostate in a man over 60 is around 30 cc's, each core only samples about 1/10,000th of the gland. Gleason grading, you can have two good pathologists, and when their score differ by one, some urologists will recommend surgery, even though they don't know the natural history of most of the diseases. And trust biopsy, and I'll show you why in a second, undergrades disease in about a third of cases. And this is the problem. Trust biopsy has about a maximum reach of about 3 centimeters from the rectal wall, so you tend to miss anterior tumors. The second problem is that prostate cancer, particularly Gleason 3+3 tumors, are a common part of aging and present in most men over the age of 60 and 70. So they find a lot of clinically insignificant cancers and feel they have to do something about it. The thing about prostate cancer is often multifocal, and so the next problem is on trust biopsy is they can biopsy this part, which is low grade, but miss the high grade lesion, which is elsewhere. So just a bit about the anatomy, because this is quite important to how the PIRADS score functions. There's only really 4 histologic zones that we're interested in. The anterior fibromuscular stroma, and that's the front of the gland. It's not a real capsule. The transitional zone, which we'll come back to, and that's the vein of all our lives. That's where we get BPH. The central zone, which surrounds the ejaculatory ducts, and then the peripheral zone, which has actually most of the glandular tissue. So if you just think about the normal anatomy briefly, there doesn't actually there's not a true capsule within the prostate, although we do see this sort of loose band of fibromuscular stroma. And it's incomplete anteriorly and apically, and that's important because tumors in those zones tend to move beyond the prostate very early. The pseudocapsule, so we now have to talk the way urologists think, and pseudocapsules, that surgical capsule around the transitional zone. And the neurovascular bundles run between 5 and 7 o'clock high up. They're quite lateral. As you get towards the apex, they become quite posterior. So if we look at a prostate, it's a conical-shaped organ. It has the central zone around the ejaculatory ducts in the healthy gland. The transitional zone is a small central and anterior located. And he has just 3 different prostates. And you see very nicely, this is the surgical pseudocapsule. This is the transitional zone with some benign prostatic hypertrophy. This is a peripheral zone. And this here is what we call the central zone. Some radiologists talk about the central gland. And if you look in the literature, the central gland combines the transitional zone and the central zone. I encourage you not to use that terminology because nobody else understands it. But here are just 3 different prostates, and you can see that the central zone can have quite a varied appearance, as can the transitional zone, which gets this organized chaos or benign nodules, which we'll come back to. Just to remind you that the prostate sits next to a lot of other organs, and so you always got to be cognizant not to miss the coexistent bladder cancer, rectal cancer, and things in the base of the penis, and we often find things there. So we're only interested really in MR 3 diseases of the prostate. Inflammation, while clinically that's the least significant, it's the most difficult to interpret at times. Benign prostatic hypertrophy, patient presents with lower urinary tract symptoms and can also be quite challenging. And then cancer, and just remind you, although I'll show you some other cases later, most cancers are adenocarcinomas. If you look at the distribution of cancers, 70% in the peripheral zone, 20% in the transitional zone, 10% in the central zone. The central zone tumors tend to be much more aggressive. And the central gland, so this is a term we don't want to use, which is these 2 areas, tumors can be mimicked by normal structures, and I'll show you some of those in a moment. So in prostate MR, there's a whole bunch of Likard grading systems. And in other places, particularly North America, they use different scales. But in America, we follow the Europeans, and we all tend to go for the PIRADS score. But as long as your urologist knows what you're talking about, there's no reason not to talk about these other scores, which are still accepted and widely published in the literature. So there was a PIRADS version 1. It was largely driven by a gentleman by the name of Jella Behrens to try put some discipline. That score has now been on through committee meetings between the Europeans and North Americans to a version 2, which was released publicly in January of this year. So what is the motivation? Because unless you understand the motivation, the score doesn't have meaning for you when you come to report. First of all, improved detection, localization, characterization, and risk stratify. To put some type of simplification and standardized radiology report technology. Most urologists have great difficulty understanding MR, in fact, even reading a lot of the sequences because there's a lot of images. And this is to try put some discipline and simplify it. To have assessment categories that summarizes levels of suspicion of risk. So just remember, MR is a risk stratification tool. It's not an endpoint. It's enabled data collection and outcome monitoring, and there's a lot of new research. Help for interdisciplinary communication. You go to multidisciplinary meetings, there's an oncologist, there's a radiotherapist, there's a urological surgeon, there's all the churches are present. We now can talk the same language. And also to facilitate MR data for targeted biopsy. When should you do an MR? Well, if you've had a biopsy, we like to wait at least 6 weeks, preferably longer. One of the things about prostate cancer, unlike many other cancers, is that you have time. And although the cancer word is very emotive with a lot of patients, the longer they can wait, the better. Because this often will affect the way you grade tumors. There is no consensus in the PIRADS document about these things, but we have now moved to giving everyone a pico prep to reduce the fecal loading and gas in the rectum. Antispasmodic, patients should evacuate prior to exam. And we now ask patients to refrain from ejaculation for 3 days to distend the seminal vesicles because sometimes a collapsed seminal vesicle can be very difficult to differentiate from tumor extension. What I like to know, and I don't always get it, but it's good to know what the current pH level is because that way you can work out the prostate density, which will come back, sorry, the PSA density. You want to know the slope, how rapid is the PSA changing, the date and results of biopsy if possible, other history like DRE, medications, and I'll come back to the medications, why that's important, particularly the alpha reductase, 5-alpha reductase inhibitors, any prior treatment, and family history. Family history I think is quite important because we have a bunch of people who are BRCA2 positive and they have diffuse high-grade tumor, but you don't see it very well on MR. So when I get a BRCA2 patient, I change my risk stratification tool down a lot. The committee recommends 3T as preferred, but not as absolutely essential. If you don't use endorectal coil imaging, 1.5T for hip prostheses, and endorectal coil for large body habitus recurrence, and obviously you can use either perfluorocarbon or barium to dilate the balloon. When you come to report, we all have to cover certain things. And again, this is covered in the PIRADS preamble. You want to localize what you think is clinically significant tumor. The problem with that definition is there's no uniform agreement amongst urologists or in the literature what clinically significant tumor is. You probably shouldn't look at a lesion smaller than 5 millimeters or 0.5 mils. You want to stage the disease locally. Remember that PIRADS can only be scored on multiparametric MRI. That having been said, and we'll come back to that later, if it's a peripheral zone lesion with greatly restricted water diffusion, it doesn't matter what the other scores are, you're going to score it a 4 or a 5. It's not there to make management recommendations, although most people recommend biopsying a 4 to 5 lesion. And dynamic contrast enhancement plays a minor role. I must say that although it doesn't make a difference in a lot of lesions, I find it very useful in when you see a lesion. I've yet to see a cancer, a significant cancer that doesn't enhance, unless they're on the 5-alpha reductase inhibitors, and we'll come back to that. We're also doing a lot of patients who've had focal therapy and scars don't enhance. So although it does help sometimes in the score, it is quite useful in looking at recurrent tumor following therapies. On every one of my reports, I put this out. What is the likelihood? What do I think the likelihood is? So 1 is very low, 5 is very high, 4 is high. Intermediate really means I'm not sure what it is, but it's too suspicious to leave alone. And 1 and 2 are very low. Just remember, prostate cancer is usually multifocal. The largest lesion usually has the highest Gleason score, and the index lesion has the highest PIRADS score. So things that interest urologists, and we report the gland volume, and that's just the maximum transverse diameters and height divided times 0.523. I must say that as the prostate gets bigger, the ultrasound score that urologists use for gland volume can be out by as much as 50%. So if you're doing measurements and there's a big difference between what they see and what we see, we usually correct when you look at the pathology specimen. PSA density, you take the PSA and divide it by the prostate volume. That is one of the risk factors that urologists use in determining risk for prostate cancer and biopsy. If you read the literature, it's probably a weak correlation, but nevertheless, that is standard practice. We map the lesions, and we'll come back to the type of template we use. I think if you're getting up beyond 4 findings, you're pushing your luck. So we probably restrict ourselves to 4, a maximum of 4, maybe 5 areas in multifocal cancer. And again, the most aggressive one is the one you give the highest score. These are the sequences we use. T1, very useful looking at hemorrhage in the gland and looking at the seminal vesicles or the tissue around the seminal vesicles. Good for nodes and bone mets. T2 for zonal anatomy, cancers in the transitional zone. Very good at looking at the seminal vesicles and extra prostatic extension. And in the transitional zone, in transitional zone prostate cancer, this is the most important sequence. So remember that BPH occurs mainly in the transitional zone, but you can get nodules which either represent ectopic BPH or herniation through the pseudocapsule sitting in the peripheral zone, and you need to pay a lot of attention because some of those lesions can look like cancers. They're usually encapsulated. They are very heterogeneous. It can mimic the ADC values and the contrast enhancement values of cancers, and therefore you pay much less attention to the ADC values. And T2 signal is the most important. So the PIRADS score for transitional zone tumors on T2 imaging, 1 and 2, you think it's normal. 3, you're a little bit worried, but I don't ever remember giving a 3 in the transitional zone. Once you start getting lenticular, non-circumscribed, homogeneous areas of signal loss, I give a 4 and a 5 if it's bigger than 1.5 centimeters. So remember T2 for transitional zone tumors. In the peripheral zone, again, if you think it's normal, it's going to be a 1 or a 2. If you think it's abnormal, it's going to be a 4 or 5. The problem with the PIRADS 2 and urologists, as we said today, we spent many years educating them on PIRADS 1, and therefore I still will not use the 1.5 centimeter as an absolute marker for 5, but rather the appearance of the lesion, because everyone is in the mind that 5 you really, really think it is, and 4 you probably think it is. They haven't migrated to the size as being the determinant, so you just got to make sure you communicate that. Before PIRADS 2 came out, we were all very interested in perfusion, and there were a lot of perfusion curves, this one being the most aggressive, this one being normal. That's all been moved aside. So the PIRADS score for dynamic contrast enhancement, you give it a 1. If there's no early enhancement, if it's diffuse, but doesn't have a focal finding on the other sequences, or if it's focal but looks like a BPH nodule. And 2, the transitional zone is a very good mark of hyper-enhancement. So if you have a lesion that parallels that in the peripheral zone, that's a type 2 and also corresponds to a suspicious finding. So here's a patient we had recently, well-circumscribed lesion on T2, some water restriction, and you can see this is hyper-enhancing even greater than a benign prostatic nodule. This would have been what we used to call a type 3 lesion. It has that type of curve, but we just said this is early hyper-enhancement. Just some technical guidelines. These are guidelines in the PIRADS 2 document. There's no uniform agreement that it adds value, although in certain circumstances I do find it valuable. Your temporal resolution, so each phase of contrast of the whole gland should be less than 10 seconds, preferably less than 7 seconds. 3D imaging is preferred. These are some of the parameters. A TR 1005 milliseconds, slice thickness of less than 3 millimeters, no gap, and try and make it the same locations as your T2 images. Make sure you get the gland and the seminal vesicles, in-plane resolution around 2 millimeters. A lot of people run the sequence for 5 minutes. It takes a lot of time, creates a lot of data. You really don't have to go beyond 2 minutes or 3 minutes maximum. Standard dose, 0.1 millimoles per kilogram of GAD, and injection rate of 2 to 3 cc's. Just want to talk a little bit about these 5 alpha reductor inhibitors. They have a very anti-angiogenic effect, so that you can have cancers and people on these agents may not show enhancement. So I just use that. You really need to know when you're assessing a lesion and the enhancement is very low or not at all if they're on these lesions. But there have been several studies with these agents to show that they have some cancer protective value. So the PCPT trial showed a 25% reduction of cancer, reduced trial for 23%, the combat trial 40%. Some of the trials said, oh, well, you get lower cancers, lower incident cancers, but you have more high-grade lesions. Now that's been debunked. It looks like it probably mostly reduces the incidence of lower-grade cancers, but the jury's out. But just to make you aware of that. Prostatitis is really the bane of our life. Prostatitis is not a diagnosis. It's like shin splints, right? Because it doesn't mean acute infection. It doesn't mean acute inflammation. It just means they have or have had something that when they go to pathology, they see a few inflammatory cells. So you can get from acute prostatitis, where the patient has hematuria and discomfort, to what most patients, they've probably had some insult in the past that's caused some inflammation, and we see it. And we'll come back to what that looks like. So When you see on T2 these ill-defined lesions, they are mostly lateral and posterior. The coronal view is very useful because they have these long, linear and wedge-shaped going down towards the vira montanum, have little or no change on the diffusion, have these streaky appearances without focal mass. That's typical appearance of prostatitis, or what I now term as the sequelae of inflammation, because they're not necessarily prostatitis in the pathological sense. So in the T2 in the peripheral zone, cancer usually are round, although not invariably, and their margins are not as well defined as benign nodules. And again, can be mimicked by prostatitis, hemorrhage, glandular atrophy, sclerotic atrophy can be very dark on MR. BPH, as we said, biopsy scars, etc., can all have an altered T2, but not all of these will show water restriction, and not all of them will show hyperperfusion. So in the transitional zone, what we look for is called erased charcoal drawing sign. So this is ill-defined, looks like charcoal on a piece of paper. It's ill-defined and infiltrative pattern. I just want to put one cautionary note. In my experience, if you have this sign, you need to call it, because a lot of these patients will not have significantly restricted water diffusion. For some reason, if you look at the pathology, many of these have a much looser pattern of growth, which means the cells aren't that tightly packed or as disrupted, and you can have high-grade tumors with minimally restricted water diffusion. I'll show you a couple of cases of that. So what are some of the technical aspects in doing T2 imaging? We all use fast-spin echo, but we make the echo train as short as possible to reduce blurring. Minimum 3 millimeters, we do 2, but just depends on your machine, your coil, etc. Should line up those locations with diffusion and DCE. We do T2 in 3 planes. Field of view, no greater than 20, depending how big the patient is or their prostate, head towards 12. We do around 14 to 16, depends. It must get above the seminal vesicles, and your in-plane resolution of less than 0.7 millimeters by 4 millimeters. Just remember, the ADC map is really just a magnitude of the slope. So if you have a restricted slope, the ADC is black. If you have a steep slope, it's white. So it's just a logarithmic function. So what are some of the technical things about diffusion? And this is quite an interesting area in all-body imaging. The ADC calculations, and that's why PIRADS 1 was always doomed to fail, because PIRADS 1 had an absolute value. If you're more than a certain number, you're at high grade. If you're less, you're low risk. And it just doesn't work like that, because you can scan the same patient on the same day and get different values. And between vendors, there's a huge difference in value. So it depends on your B-value. And therefore, you have to rely on a quantitative assessment. You have to get used to what looks like restriction rather than the measurement. And 750 to 900 is just a very vague guideline. If you don't have time and you can only do 2 values, your lowest value should probably be set at around 50 to 100, and your highest should be at least 800 to 1,000. And any additional values are better because it improves your value or your measurement of the ADC. Higher B-values, we've been doing high calculated B-values, and this is a very valuable tool. Now, you can either do that by directly measuring it and doing a long sequence at a B of 1,500 or 2,000. We prefer to do an extrapolated calculated value. Why is that better, in my opinion? Shorter scan time, and you're taking data when there's much more signal to noise because you're taking it from the shorter scan B-values. We'll come back to why that has a role. And generally we do free breathing spin echo, and these are some of the factors which I think Daniel will probably talk a little bit about those. So the high B value, there is some evidence and tends to work a lot of the time. When you're struggling about a lesion, either in the peripheral zone, but particularly in the transitional zone, as you take your B value up and your high calculated diffusion image, the benign lesions tend to go down in brightness and less dark, and the malignant ones stay. In fact, if anything, they get more conspicuous. And The data is yet to be published, but it is useful, not always, but a lot of the time. But there are some caveats with low ADC. Calcification can mimic fibrosis, but good thing about fibrosis, it tends not to enhance. Fibromuscular stroma, which is just that part, particularly in the basal third of the gland and to the anterior to the neck of the bladder, there's always dense, low T2 fibromuscular stroma. It doesn't enhance and doesn't have water restriction. Hemosiderin can, some BPH nodules. Granulomatous prostatitis, I don't know how you tell the difference, but it can look like cancer in every way possible. And it's always easy to make the diagnosis in hindsight. And abscess. Abscess is quite easy with a diffusion. So this is what you'd call a low risk. So when I assess, before I give a score, I decide in my mind what the risk is. And this would be as close to PIRADS 1, although I very rarely give a PIRADS 1. Nice homogeneous peripheral zone, well-defined nodules, nothing on the diffusion, doesn't even enhance at all. And this is this beautiful shaped prostate in the coronal view. If you notice the shape of the prostate, it's heart-shaped in the normal, and that's because a man always wears his heart close to his penis. Mid-zone, so we're now seeing these streaky little densities. There's no discrete mass and no water restriction. That's a PIRADS 2. Prostatitis or inflammation classically, and when it's classical, it looks like this. It's always the posterior half of the gland. It's ill-defined and smudgy, has mildly restricted water diffusion, can hyperperfuse. On the sagittal is this ill-defined, smudgy outlook. When I see that, I think inflammation, PIRADS 2. Compare that to this case. Here is dense loss of signal. The capsule is irregular. You can't even see the pseudocapsule. There's diffusely restricted water diffusion. This is diffuse high-grade tumor. So those are the opposites of the spectrum. Those are the easy ones. It's the ones in the middle that we're angst about. In the mid-zone, here's another tumor. Sorry, here's another area of abnormality. You see this semi-well-defined area. It has minor water restriction, but on the sagittal is very linear. It has no mass to it. That's a PIRADS 2 lesion. Compare it to this lesion, which has much more discrete T2 loss, has water restriction and mild hypertension. This is a cancer, so this is a Gleason 3+4 cancer. Another thing to be cognizant of is at the apex. Here is a typical apical tumor coming out. It's restricted water diffusion. But what I want to point out is this is the zone of continence. So this is where the membranous urethra stops. This is a very important area. Notice on the sagittal it has got scraggly margins. It's not well defined. This is very important because if you don't alert the urologists, they leave tumor, but if they take it out, then there's an issue of continence. There's some errors. So the neurovascular bundle can often give you this area of water restriction. And because on diffusion, both the prostate, its capsule, and the periprostatic plexus all look like prostate, many times I've seen this lesion called a tumor. It's actually outside the prostate. It's here. And here's another one. You see this nodule of water restriction. It's actually in the neurovascular bundle. So that's one of the pitfalls. So in the transitional zone, a well-defined nodule like this is low risk. Even you ignore all the other parameters. Compared to this, he has an anterior tumor. It has ill-defined margins. It's quite restricted. This is typical elliptical shape. This is what a cancer looks like. And then when you put on your report to help guide any biopsy, whatever method's used, so we use this template. You can use higher number of templates, but we put it and we send this out with a marking of where the lesion is in all three planes. Just to kind of, the value of MR in informed biopsies, increased biopsy yield. We most of the time will find the relevant cancers, and particularly in people doing truss biopsies, not so much as transperineal, the anterior and apical tumors are missed. When you stage, you also got to talk about capsule, seminal vesicle, bladder, and lymph nodes. And there are many objectives in staging, but I think I've just seen Phil arrive, so I'll leave that to him. Just remember, if it's T2 or less, it's confined to the gland. If it's T3 or greater, it's outside the gland. And here's the T staging. Each one has A, B, and C. Not a topic for tonight, but you stage the tumors. So if there's contour deformity of the capsule, irregular bulge, capsular breach, and direct tumor extension, obliteration of the retroprostatic angle, or asymmetry of the neurovascular bundles, that's disease outside the prostate. So here you see subtle, but this pseudocapsular line is gone, and you can see these very irregular capsule. That's prostatic extension in the rectoprostatic angle. Here's an obvious one, big tumor. This is going into the neurovascular bundle. Here's direct involvement of the neurovascular bundle. This is one of the lesions I want to tell you. Here's an anterior lesion that goes into the transitional zone. Note that the water restriction is not as marked as you'd like to think. Some of these anterior tumors do not have a lot of water restriction. Seminal vesicles, what you look for, here's a normal seminal vesicle. It's very useful both in the coronal and sagittal plane. Here's a tumor. This is in the distal seminal vesicle. You can see it in the coronal plane. Here's the seminal vesicle coming down. And in the sagittal plane, you see the vesicle just before it pierces the prostatic pseudocapsule is involved. Nodes, same as elsewhere, short axis of greater than 10 if oval, 8 if round. We see them on T1 or post-contrast images, very important to find, although we understage nodal disease on MR because we don't see the normal size nodes. And here's just an example of lymphadenopathy. Just a couple of quick pitfalls. I've got 3 more minutes. Biopsy. If you don't recognize post-biopsy change, you can it can alter your grade, although generally it doesn't cause water restriction. We have had cases that have come back where your radiologist hasn't recognized biopsy and they've come back with diffuse high-grade tumors that can cause water restriction. I think when it goes through that stage where there's a lot of hemorrhage and it's forming maybe small amounts of clot, it looks restricted. But here's the thing we call the tumor sparing sign. So often you have a lot of biopsy and you have a high-grade lesion. For some reason, the hemorrhage doesn't involve the high-grade lesion. So here's a T1 image. You can see the lesion is dark on T1, it's spared. It's dark on T2, shows water restriction, and it hyperperfuses. Hematoma doesn't hyperperfuse. The central zone, which occupies the basal third of the gland, can look like anything. It can look like tumor, it can look like, has kind of water restriction and hyperperfuse. So the 2 signs is, first of all, in the coronal plane, it has this very triangular appearance. If you can see, as you can in most cases, the ejaculatory ducts are normal, that's a very good ancillary sign that this is not a tumor because the ducts will get involved very early on. But again, it's always the basal third of the gland, and you just need to be aware it can mimic tumor. As I said, granulomatous prostatitis, you can see here's a lesion. It's low on T2, shows bright diffusion, shows water restriction. I don't know how you tell the difference sometimes. Chronic prostatitis can cause scarring, but these scars tend not to enhance. And you can see there's volume loss, and prostate tumors don't cause volume loss and they'll have been treated. Abscesses, here is a lesion that is bright on T2, maybe slightly bright on T1, but shows water restriction. And I think abscess most of the time you can tell because it's a small lesion in a big area of inflammation. And here's another one, bright on T2, so it's not tumor, has some T1 signal, which is proteinaceous fluid and water restriction. Not all things are adenocarcinomas. This is a sarcoma of the prostate. You can see this very large heterogeneous lesion. This is lymphoma of the prostate. Just to wrap up, the next thing we have to add value is MR truss fusion or MR transperineal biopsy fusion. And there are 3 modes. Cognitive, the urologist experience, he sees a lesion, he says, I think that's where it is because you can't usually see them, and he puts a needle there. And now you have MR ultrasound fusion, either non-deformable, which means when you put the ultrasound probe in before biopsy, it doesn't correct for the deformity, and now the new ones will actually correct for deformity of the prostate. And here's just a patient we had. We thought this was a lesion, and the urologist put some extra needles there because they wouldn't normally go there, and he had a tumor. Thanks very much.
I'd like to introduce Daniel Moses now, who's the Director of Radiology at Prince of Wales Hospital. And Daniel's going to speak to us on mpMRI guided diagnostic biopsies and its results.
Excellent, thank you. Ron's just outlined prostate MR and the PIRADS system, and now I would like to talk about a study that we've all done together, looking at the performance of mpMRI in its ability to detect significant prostate cancer and then to guide diagnostic biopsy. Just as any study has a lot of people that are involved, and we had a lot of people involved in this study, including urologists, radiologists, anatomical pathologists, and other research staff. I've just listed them there, and this was truly a collaborative effort from many different centres around Sydney, but driven by the St Vincent's Prostate Cancer Centre. So, early detection and management of prostate cancer is a challenging issue. PSA is good and demonstrates survival benefit, but does have considerable overdiagnosis and overtreatment. At the moment, truss biopsy, a 12-core template truss biopsy, is currently the standard of care in a patient with either an elevated PSA or abnormal DRE or both, but it does have its limitations, and they include sometimes failure to detect significant cancer because you're only taking 12 cores, or over-detection of insignificant cancer. Saturation biopsies can help improve these detection rates, but by oversampling, you also increase detection and complications. So, as Ron has shown you, and as radiologists, we know that multiparametric MRI provides the best anatomical and functional imaging of the prostate when compared to any of the other modalities. But despite this, there are a lot of MRI studies out there that have methodological limitations, and these include things like reporting bias, selection bias, the correlation with suboptimal histopathology, and various other limitations. Also, there aren't many studies out there that try and match up and give you anatomical correlation between what you're seeing on the MR and the histopathology. So we attempted to, we did conduct a study, which was a prospective cross-sectional study to look at the overall and lesion-specific accuracy of MRI for clinically significant prostate cancer, and we'll talk about clinically significant prostate cancer in a second, before diagnostic biopsy in men who have either a PSA, increased PSA or an abnormal DRE. So the usual chain of events is that if someone has an abnormal DRE or PSA, they go on to biopsy. Well, we interposed MRI for the biopsy and then had a look at how that related to the detection of cancer. So in terms of a good study